I'm Sherry Larkins from UCLA, and I am joined by the Azusa Pacific team, as well as Dr. Brian Hurley.
Hello.
And we are going to get started today. We have a kind of a fun Ask the Expert. We have our fabulous expert here, Dr. Hurley. But before we get started, I just want to give you a little bit of background if you're getting continuing education today, just to give you a little background of the project. This is part of what's called PCSS. It's Providers Clinical Support and sort of network, essentially, that SAMHSA funded. And Rachel Castaneda from Azusa Pacific, along with Dr. Linda Reed from the nursing program at Azusa Pacific, are co-directors of the project. And essentially the goal is to expand nurse practitioner training and really in some ways to try to get advanced practice practitioners like nurses and nurse practitioners and PAs kind of excited about the idea of actually prescribing medications for opioid use disorders, in part because we have great need and we have, you guys have, skill sets to be able to do this. And so we'd really like to bring you an opportunity to get the training as well as get sort of engaged with experts in the field who are already doing it and can kind of help provide some of that technical assistance that you might need. In some ways, what we see is that people often will be interested in getting the additional training to prescribe, in this case, buprenorphine, but then sometimes there's a drop off and with them actually prescribing. So they receive the training, but then actually never sort of implement that practice. And so our goal is to try to encourage people to get the training and really start to get interested in prescribing. So before we get into some activities, I just kind of wanted to give you a little bit of, there's this session today, which we're going to have Dr. Hurley go over kind of some earlier phases of clinical practice with respect to medications for opioid use disorders. We're going to talk a bit about what FDA approved medications are available. And we're going to hone in on buprenorphine and also talk about, basic induction, like a first visit and what it looks like and what follow-up visits look like. And in a week, we're actually going to also have another expert panelist who's going to be Dr. Matt Torrington, who's going to go over some cases, a little more complicated cases. So like maybe patients who are pregnant, how do you treat them? Maybe patients who have co-occurring mental health disorders or on other medications. So these two sessions are really kind of more clinical or practice focused. And I'll let Brian introduce himself. Why don't you take it away, Brian? Let us know who you are.
Sure. So I'm Brian Hurley. I work as the Director of Addiction Medicine for the Los Angeles County Department of Health Services. I'm a psychiatrist by training. I'm also trained in addiction psychiatry, and I have a board certification in addiction medicine. It's a pleasure to be here with everybody.
Thank you. And I think one of the things that makes Brian's skill set unique is that not only is he, a practicing physician, he's also an educator and teaches and also does research. So he's kind of the trifecta of the things that you want when it comes to a clinician who's actually doing research and is able to teach. So Brian, welcome.
Thank you.
One of the things that we talk about is why are we all here and why are we even considering medications? And there's a couple of things that are important to highlight is that our field has been very stigmatized. And so the idea of using medications to treat a substance use disorder is sometimes kind of a challenging concept for some folks. And we do have very robust medications for alcohol use disorders, opioid use disorders, and tobacco use disorders when it comes to sort of the range of substance use disorders. And so we want to make sure that you feel equipped as you leave graduate school and enter the field to know that there are good medications out there and how to provide good quality care. And we know that these medications work. There's a lot of data for many years supporting research that is supporting the use of these medications to improve outcomes for people with substance use disorders. Now, in some ways, when you kind of start prescribing, there are some institutional and organizational things that have to be in place. And the point of our kind of next couple of sessions is not really to go over too much detail on those, but certainly to link you with those resources. And the organizational readiness type of stuff focuses a lot on policies and procedures that are in place. How are you going to get billed for this new service? How are you going to be billing for this? How do you get paid to do it? How do you work with pharmacies to make sure you have access to the medication? And, things like, how is your staff going to be trained? What do they need training in? Is it just skill set, or is it really knowledge? Is it things around stigma? There's a variety of things to consider as your organization begins to provide medications for opioid use disorders. But what we're going to really talk about today is kind of more of like the clinical piece of what the prescriber is doing with the patient in sort of once a patient is screened and identified, and even how, as a prescriber, how do you make decisions about what medications to choose? How do you work with patients who have some concerns or resistance around this? So today and next week, we're really going to focus more on those sort of clinical aspects, a little bit less on the organizational components of this. So one of the things that we talk about is before patients get on medications, how do we identify them? How do we know that they're a good candidate for medications? How do we do comprehensive and thorough sort of assessment? What are the things that we look at and identify as being necessary before we begin prescribing? And at this point, these are kind of some things that we go over, but at this point, I think what I'd like to do is I'm going to hand it over to Dr. Hurley, and he's going to describe a little bit about the 3 FDA-approved medications, which are naltrexone, buprenorphine, and methadone, and how, with a focus on buprenorphine, also known as Suboxone, and how these actually work. So Dr. Hurley, why don't I have you take it from here, and then you just tell me when you want the next slide.
Sure. So let's talk about the medications for opioid use disorder. As Sherry mentioned, there's methadone, there's buprenorphine, and there's naltrexone. Methadone sort of works as what's called a full agonist. The more you take, the more effect there is. If you take too much methadone, you stop breathing. It's relatively straightforward. How methadone works for opioid addiction is if somebody's using heroin or say a prescription medication like Norco, Percocet, Vicodin, oxycodone, or OxyContin, and there's many more types of prescription opioids. When the opioids come off, when they're metabolized off, and if somebody has a sort of chronic opiate addiction, they go through opiate withdrawal, and it's really dysphoric. In fact, it's so dysphoric that this is one of the reasons that people leave the hospital, against medical advice. And one of the reasons that we use methadone to help treat opioid addiction is that it takes somebody that's in the cycle of like getting high and then getting sick and then getting high and then getting sick, and sort of this up and down cycle. And methadone has a couple advantages. One is it's slow to absorb. So oral methadone sort of works more slowly than other opioids when taken orally. And it's super long acting, right? The half-life is like, usually 20 plus hours for some people, the half-life is like 60 plus hours if they're a slow metabolizer. So you go from like this to this, and it alleviates withdrawal. It alleviates craving. When used appropriately, and there's sort of protocols you follow for starting a patient on methadone for addiction, usually it's really well tolerated. And sometimes people ask, well, what's the difference? Methadone's an opioid, heroin's an opioid. What's the difference? The difference is the half-life and the context. So heroin, you typically get from a heroin dealer, right? You smoke it, you snort it, you inject it. Methadone can only legally be administered out of a federally licensed methadone clinic. So unless you're going to go work as a nurse practitioner in a federally licensed OTP, you won't be prescribing this for the indication of opiate addiction. And so, but when used appropriately, actually it keeps people engaged in treatment. It reduces the overdose rate by basically tenfold in most studies, reduces drug use. It's funny, I studied the way the United Kingdom treats opiate addiction, and they encourage primary care doctors to prescribe methadone for addiction. Unlike the United States, we have to send the patient to a particular clinic. In the UK, it's more democratized. Almost anyone can prescribe methadone, and you're dispensed it out of your community pharmacy. So rather than need to go to a one place in your neighborhood, you can go to there it's Boots, but here at CVS or Walgreens, you go to your community pharmacy in order to sort of get your dose of methadone. But the key is it's observed, right? So it's a way of helping support patients take medications appropriately. And they find that crime went down, incarceration went down, overdose deaths went down. HIV rates in the United Kingdom are much, much less than the HIV rates are in the United States among injection drug users. And a lot of this is due to the effect of methadone. So methadone's a highly effective medication. And the one sort of message to take from here is the actual clinical use of these medications is not particularly complicated. It's the regulation, right? In other parts of the world, they use methadone routinely out of community health settings in order to treat people with opiate addiction. In the United States, it's got to be out of a federally licensed OTP, mostly out of the federal government's anxiety. So buprenorphine is a different medication than methadone is. It's an opioid like methadone, but unlike methadone, it's got what's called a partial agonist effect. With methadone, the more you take, the more you get, right? If you take too much, you stop breathing. With buprenorphine, it has an opiate effect. It alleviates withdrawal. It helps suppress cravings. But you hit a ceiling, and that ceiling is roughly around 32 milligrams. So after somebody takes 32 milligrams of buprenorphine, they don't get any additional opiate effect. And in fact, it's very hard to kill yourself with buprenorphine. It's virtually impossible to overdose on it on its own. And the only people that really overdose with buprenorphine are the people that inject it along with other CNS suppressants like diazepam, alprazolam, other benzodiazepines or barbiturates. So the ceiling effect makes it safe. Even if somebody took large doses of buprenorphine, usually it doesn't cause respiratory arrest. But unlike methadone, buprenorphine is really, really potent. That is to say, a little bit sticks on the receptor, and it just doesn't fully activate the receptor, but it's sticky. So it's what's called a high affinity partial agonist. Its affinity to the receptor is much higher than virtually any other opioid. And as a consequence, in order to walk a patient through how to start buprenorphine, what you do is you tell them, stop using heroin or whatever other opioids they're taking. Wait until you're a little bit sick. Wait until you're feeling a little bit of opiate withdrawal, and then take buprenorphine. Because if you take buprenorphine too early, if you take it while you're high, buprenorphine can actually accelerate withdrawal. It can what's called precipitate withdrawal. Because if you take it while you're actively intoxicated, buprenorphine will outcompete whatever opioid you're on. With that instruction, actually, we now routinely prescribe people buprenorphine for the indication of opiate use disorder. You can do it at primary care offices. You can do it out of the emergency room. You can do it out of a hospital. You can do it out of a mental health clinic. Almost any setting of care, the mechanics of how to start buprenorphine are pretty similar. And what's different about buprenorphine is that unlike needing to send the patient to a methadone clinic, right, a federally licensed OTP, patients can get it in almost any setting with a provider who has something called an X waiver, and that's sort of listed on the slide. So like methadone, buprenorphine helps reduce overdose. Like methadone, it helps people stick around in treatment. But unlike methadone, you can prescribe it. You as nurse practitioners can prescribe it in any setting where you work, right? If you're working inpatient, outpatient, in specialty care, in primary care. In any setting of care, buprenorphine can now be prescribed as long as you have something called an X waiver. But the regulations are complex, right? So you have to do this training, and then there's a certain cap on the number of patients that you can have treated with buprenorphine at any given period of time. It's something that, if you get X waiver trained, we'd talk about. Next slide.
Brian, I have a quick question for you.
Totally.
You mentioned because of the regulations, so these folks are nurse practitioners.
Mm-hmm.
So in addition to the 8-hour waiver training, they have the additional 16 hours, so 24-hour total amount of training. You also mentioned sort of the regulations around methadone. Are these kind of, I don't want to say barriers, but these extra regulatory things, including a lot of extra training, are those just kind of related to like the stigma of being a substance use disorder medication, or are there profiles within the medications themselves that would dictate that we really need to be this regulated? And in some ways, I'm just trying to even prep them for that extra 16 hours. Like,
yeah, totally.
What are they getting out of that 16 hours that's different than the 8 hours and, that kind of stuff?
Yeah. So the regulations are driven essentially by stigma and by lawmaker anxiety. There's really no good clinical reason.
Okay.
Methadone is a long-acting full agonist opiate, but I am legally, right, with my DEA registration and my medical license, or with your, medical license you get as a nurse practitioner and with your own DEA registrations, able to prescribe unlimited amounts of OxyContin, unlimited amounts of, what's the right word? Hydromorphone, right? Dilaudid, right? Super high potency, super high dangerous opioids. And there's really no federal regulation around those. Methadone's much safer than those, than many others. The danger, the reason we have protocols with methadone is because it's easy to get a patient titrated too fast. And because of the long half-life, metabolites will build up and somebody might like stop breathing overnight because not because they took too much like all at once, but because they've taken too much recently and the metabolites build up. Those protocols, again, aren't that complicated, but we don't usually teach them outside of an OTP because we can't, it's not legal to prescribe methadone outside of an OTP for the indication of opioid use disorder. But with buprenorphine, I guess the biggest thing you learn in the X waiver, I can teach you in about 5 minutes, which is make sure the patient's in withdrawal before they start taking buprenorphine. That's the big risk, right? Is precipitated withdrawal. Which is not medically dangerous, right? Like it's not, precipitated withdrawal is uncomfortable. It's flu-like symptoms, right? Somebody might be crawling out of their skin, but they're not, stopping breathing.
You're not going to kill them.
It's not going to kill them.
Okay.
So that's really the big reason for the training was, of the people that first studied buprenorphine, is they didn't want patients to get turned off from buprenorphine because people were not preparing the patients for how to take it. And so the X waiver training really existed to prepare practitioners, physicians, NPs, and PAs on how to prepare patients to take it appropriately. That's really the big reason.
Okay.
And what do you get with the exercise? So keep in mind the 8 hours, the 24 hours, this was decided in DC. Nobody ever sat down and did like a trial to sort of like evaluate the optimal number of hours. This was totally picked arbitrarily. And so the organizations like PSCSS that come up with 8 hours, you sort of think through what sounds reasonable given the context. And the additional 16 hours are things like motivational interviewing, toxicology testing, how to talk to drug users. But there's nothing technical in the 16 hours that is really clinically necessary. It's more to satisfy a regulatory mandate.
Okay. Because one of the things is, so many people who get the initial training but don't start prescribing, they feel that things are a little daunting. And I think there is this kind of anxiety about, wow, this is a new population, or this is going to be a lot of work. And I had to go through 24 hours of training means this must be super complicated.
It must be super complicated. It's not.
Okay.
Yeah,
okay.
It's not.
Okay.
You'll leave today knowing how to prescribe buprenorphine. That's the easy part. The clinical part and the safety profile of buprenorphine. I mean, buprenorphine is safer than insulin. It's safer than metformin. It's safer than atenolol, or it's safer than a lot of the meds we routinely use in general healthcare. So, so I think the anxiety exists as a side effect of the rules. It's not because of anything clinical with the medication.
Okay, great. Thank you.
So buprenorphine exists in the most common form is sublingual. It actually has poor oral absorption, so patients never really swallow, or it doesn't work. If you swallow buprenorphine, then it gets eaten up with the first pass metabolism. But it goes sublingually. You put it under the tongue. There are films and there are tablets. The tablets used to be made by a company called Reckitt, and it was called Suboxone. And so people still call the tablet Suboxone, even though actually Reckitt no longer makes the tablets, and all of the tablets now are generic. So there's buprenorphine. And I don't think there's a Subutex film unless I'm mistaken, but there's a Subutex tablet, and there's a Suboxone film. The difference between Subutex and Suboxone is naloxone. So we co-formulate in the United States our buprenorphine with naloxone, and that's the version that most of us prescribe, or actually that all of us prescribe, because I mentioned how do you kill yourself with buprenorphine is if you try to inject it. If you put buprenorphine under the tongue, or Suboxone under the tongue, the buprenorphine is absorbed, but the naloxone that's co-formulated in it is not. And so buprenorphine with naloxone, if you put it under the tongue, is the buprenorphine is bioavailable, it's absorbed. The naloxone isn't, and is equivalent to whether if you just took buprenorphine with naloxone or buprenorphine without. The only reason we add naloxone to buprenorphine is to try to dissuade patients from injecting it or snorting it. When you inject it or snort it, the naloxone is absolutely absorbed through the nasal mucosa, or is absorbed if you inject it, although calling it absorption is kind of funny. It's just you're injecting yourself with Narcan. And it will cause an adverse reaction, not a dangerous reaction, but it causes an acute opiate withdrawal if somebody was to inject themselves with Narcan if they had a physiologic opiate dependence. So the buprenorphine with naloxone is the same as buprenorphine without naloxone when taken as prescribed, but the naloxone adds this sort of safety. It's like this aversive agent that makes people less likely to take it in a way that's not prescribed. So for most of us, we just prescribe buprenorphine with naloxone, which is Suboxone. And the films come in 2s, 4s, 8s, and 12s. The tablets comes in 2s and 8s. And then there is a different brand name called Zubsolv, which is they advertise higher bioavailability on their tablet. And then there's a buccal film that goes on the cheek. It's supposed to under the tongue. That's called Bunavail. And now there's a subcutaneous injection called Sublocade. And then the FDA is currently evaluating a novel agent called, that will be marketed under the name Brixadi, that is an alternative injectable. So right now, there's one injectable, there's another injectable coming to market, and then there's 2 types of films and 2 types of tablets, and then a buprenorphine-only tablet.
Brian, with the Sublocade, I remember when that got FDA approved, people felt like that would hopefully be a game changer because you have the medication on board for a month, or is it 30 days or something, or maybe? It's
a monthly injection. And the nice thing about it is that patients then don't have to take it sublingually. There is a black market for Suboxone. There are people who take it on the street, and it's not to get high. Actually, people take it on the street to alleviate withdrawal. Like they themselves are tired of this cycle of like high and sick and then high and sick. And so what they do is they find somebody who's got, when they're ready to take a break, right? They're like, hey, do you have any Suboxone? I need to like chill out for a minute. I don't want to get sick, but I'm not going to use any heroin for the moment. And so they use it as a way of sort of self-treating withdrawal. So there's a black market for it. And one of the nice things with the Sublocade injection is that patients that keep losing their prescription, patients that keep selling their prescription, patients that might inject or start their prescription, patients that you might be worried, can they safely manage it? Previously, those patients were sort of like directed to an opiate treatment program, right? They had to go to a methadone clinic and be observed taking their doses every day. Even if they didn't take methadone, you can still go to an OTP and be observed taking your buprenorphine. Sublocade became this middle ground of, right, like, well, we don't think that the oral or the sublingual medication is appropriate. And I treat in the public sector. So a lot of my patients, like the diverting, selling, losing their meds, that sort of thing. For patients that have more psychosocial stability, some patients don't want the convenience. They just don't want to have to remember, they don't want to have to take something sublingually. And Sublocade is also appropriate for those patients. And the last thing is that its use is really limited by its cost. So you can get Sublocade in now many sort of private addiction treatment programs. Some of the insurance-funded ones will now do it, like Tarzana is doing Sublocade now. But and Medi-Cal has now made Sublocade available without a TAR. It's just getting public sector programs to, like, again, deal with the regulations. You have to fill out like a REMS form. And there's this whole process, and you have to store it in a double lock fridge, which not a lot of community health centers have. But clinically, I think it's a great medication. It's just an issue of like working out the logistics. It's the organizational readiness piece that I think has limited our current use of Sublocade. But I'm excited. I think that as the price comes down over time and as more people use it, we're going to see we're going to see a lot of patients benefit from injectable buprenorphine.
Great, thank you.
So we mentioned a full agonist, which is methadone. The more you take, the more the effect. There's a partial agonist, high affinity partial agonist, that's buprenorphine. And that's the medication that, in the United States, most medications that are used to treat opiate use disorder, they're buprenorphine medications. But there's a last option, which is an opioid antagonist. It's called naltrexone. The injectable version is called Vivitrol. What makes naltrexone different than buprenorphine is it's purely an antagonist. It binds to and blocks the opioid receptors from being activated by anything else. So if you are on an injection of naltrexone, and it's like with Sublocade, it's a monthly injection. So if you're on monthly injectable naltrexone and you try to use heroin or oxycodone or whatever opiate on top, it's going to blunt your response to any opiate that you take. It actually also works for alcohol use disorder. The thought is that it also eliminates that craving circuit that exists in the brain, sort of rehearsing the high you would get or the buzz you would get from drinking alcohol. The long-acting injection works pretty well for opiate use disorder. The challenge with naltrexone long-acting injection is twofold. One, not every patient likes it, so the discontinuation rates are non-trivial. The discontinuation rates from buprenorphine are also non-trivial, but the 12-month treatment retention with buprenorphine is like 50%. Roughly half of patients stay on buprenorphine over the course of a year. It's less than 50% for naltrexone long-acting injection. Not a lot of patients stay on it for very long. And the other thing that makes it more difficult to use is, unlike methadone or buprenorphine, which you can give to a patient like the day they use, right? If somebody's been using that day, you just prescribe them buprenorphine. You say, okay, wait until the heroin wears off and then take your first dose of buprenorphine under your tongue, and patients feel okay. With naltrexone, you have to actually get the patient detox. They have to be fully weaned off, or what's called detoxed off, of all the opioids they're taking, and stay off of opiates for 7 days. And one of the big drivers of relapse is, ironically, abstinence, right? Like people that detox off opioids, the relapse rate is like 100%, unless somebody goes on to do some kind of treatment. And so the concern with naltrexone is that 1 week, right? If they detox off opioids, can they last the week unmedicated, not on buprenorphine, not on anything, not using? And for this reason, a lot of patients that get onto naltrexone are patients in rehab, right? They go to residentials or they go to settings where they can be supported staying off opiates. And that's, again, if you're in primary care, a non-trivial concern of like, okay, if this patient, I want to get on naltrexone, how do I get them off the opioids, then probably get them into a setting where they can remain opiate free for long enough to get the shot. So that's made the use of naltrexone, particularly in primary care settings, more limited. But interestingly, it seems to work just as well as buprenorphine does for the people that get on it. It's people come off naltrexone somewhat more frequently than people come off buprenorphine. And from my vantage point as somebody that uses these medications for patients, the patients that do well on naltrexone are the people that really want to be off of all opiates. They don't want to be on methadone. They don't want to be on buprenorphine. And the patients that are really motivated do really well. But I probably wouldn't try to force naltrexone onto a patient that really wasn't interested in this particular treatment.
Okay. So it sounds like for a patient who can make it that 7 days or is in a setting where it's
feasible,
they've got that wraparound, it can be a good option.
That's right.
What are the big things that you do before you begin prescribing? I mean, I kind of made a list here, but like before you even start, where do you start with patients?
Well, so there's not. I'll tell you what I do, but I also say that reasonable people sometimes disagree with this. So where I put the prescribing is probably earlier in the pathway, or I will say is earlier in the pathway than the typical waiver training would probably say. So you screen, and there's a bunch of screening tools. The one I've been using lately is called the TAPS, which is the tobacco, alcohol, and prescription and other substance use, the TAPS. It's 3 items. Well, it's the NIDA quick screen, which is 4 to 5 items if you count marijuana separately. And then based on somebody's response to the NIDA quick screen, there's like 3 additional questions per substance. So that you would ask somebody around their opioid use. And if they screen positive, right, they screen for somebody that, reports illicit substance use of an opioid or reports non-medical use of prescription opioids. Then you do a diagnostic assessment. There's something called the DSM-5 criteria. There's 11 criteria that are lumped. I sort of lump them into loss of control over the drugs, cravings around opioids, and then and then consequences, right? Problems related to the opioid use. And somebody now has a diagnostic assessment for an opioid use disorder, then I would want to see, are you already on a medication for opioid disorder? Are you on methadone? Are you on naltrexone long-acting injection? Are you on buprenorphine? You do a medication reconciliation. At that point, I'd ask, are you interested in a medication for opioid use disorder? And the reason that I would ask at that point is I don't want to just let that diagnosis go by the wayside, right? I don't want to miss the opportunity to capitalize on it. And the truth is, there's actually no lab test that's a contraindication of buprenorphine. You can have high LFTs, you can have anemia, you can have a white count. Doing lab testing is important, but I tend to prescribe even before I do labs, with the idea being that the labs really don't change my decision of whether I'm going to prescribe or not. I also think doing a complete HMP is important, right? Like what's going on with them medically, what's going on with their mental health, or they have other substance use disorders. But the fact is, alcohol use disorder is not a contraindication. Methamphetamine use disorder is not a contraindication. The FDA has said don't withhold buprenorphine from people that take benzodiazepines. So benzodiazepines are not a contraindication. So I sort of do screening, diagnostic assessment, offer buprenorphine, then history and physical, because assessing patients is important. I'm not saying that we shouldn't,
right,
but I sort of say med first, right? Let's do a medication that's going to keep us engaged, keep you out of withdrawal, keep you alive. And that may give us time because, you may not be willing to sit for a full evaluation. Okay, right? But at the very least, if I give you buprenorphine, you're likely to come back for a refill. That gives me time to complete my assessment if the patient left early. So then I would get my labs, ideally at the same visit if possible. Is the patient in withdrawal? If they are, that's a really good reason to prescribe them buprenorphine quickly because that's a tool to get them out of withdrawal. And then how do I pick which medication? Well, is the patient willing to go to a methadone clinic? Have they done poorly on buprenorphine in the past? That's a good reason to go to a methadone clinic. Can they be safely trusted to handle their medications? And I prescribe buprenorphine to people who are homeless. I prescribe buprenorphine to people that do not have a lot of stability. But if somebody really is look, I just don't have a place to store my meds, sending them to an OTP where they're, daily, they're offered the medication, they physically go pick it up every day, is inconvenient for the patient, but might be a better option for them. Otherwise, I'm starting most of my patients on buprenorphine, right? Buprenorphine becomes the default. And then if a patient's nope, won't do it, I really don't want to be on any opioids at all, but I want to detox and I want to come off of opioids, that sort of leads me to Vivitrol, right? That leads me to naltrexone because that's a medication that will help them come off opioids altogether.
I'm only moved to this slide because you're getting on some of these good questions.
Oh, yeah.
about sort of where, so it sounds like it's this sort of medication first is really let's engage them, let's hook them before, there's hardly any other areas of medicine like mental health or anything where we say oh, we're not going to give you anything for depression or anxiety until you've jumped through all of these hoops.
That's right.
So it sounds like, and it from what you said, it sounds like buprenorphine is the good sort of, you can go more intense to methadone if you need it, if they need more structure, or if they're maybe their use level is higher or something.
Higher, yep, that's right.
Or you can go down to something like Vivitrol if they see, if patient selects to sort of be off everything, if they can go through the withdrawal that they need to go through and things like that.
And if they're motivated, that's right.
I see.
But I think of buprenorphine as the default choice, and you can sort of click up to methadone, or you could click sideways to naltrexone. You know what I mean?
Okay.
But I think of buprenorphine as the default choice.
Okay. I put in here one of the questions. What do you do when you sort of balancing patient choice? Do you have patients, because our medications for addiction treatment are pretty stigmatized? Do people come in and say I don't want to be on anything, or I have to be off everything? Or do they come in with a very clear idea? Do you ever have to kind of work with that? Any resistance with the patients where you have to do more education to kind of help them understand this, or
Yeah, totally. So I trained in Boston and New York, and in Boston and New York, these medications are routinely used in most settings. And so I didn't find when I was in Boston and then when I was in New York that I had to do a ton of education. I did some, but most patients had at least heard of methadone, Suboxone, and Vivitrol, right? Those weren't new necessarily to the lexicon. In Southern California, where I live now, these really are new treatments for a lot. There's a lot of people that work in healthcare that have not heard of or used these medications before. And there's a lot of patients in the community that have never heard of or used these medications before. And the model of let's detox you and then get you through like a 28-day program and then, going to meetings is really remains the dominant model for addiction treatment here in LA. And the challenge with that is the relapse rate's like 90% after when you look after a few months, right? Most people with opiate addiction aren't able to achieve abstinence without medications. Now, that's not to say you can't, right? There are plenty of individuals that achieve long-term recovery without medications. But I find myself sort of talking to patients around, like, if you're going to go with psychosocial treatment, like, are you really ready to do that? Because that's a lot of work. It's a lot of time. And then I educate, because, we have a tool that can keep you out of withdrawal, right? Like, you don't even have to necessarily stop using heroin altogether, but this is a medication that can like help you stop from getting sick. It can help keep us engaged, right? Like, now you're coming back, it gives me a chance to, get future appointments and work with you. And educating people about what the medication, how it works in this part of the country is still a really important thing. And so I do try to spend a lot of time talking to patients around, the medication. And I'll tell you, there are patients that I meet, they don't want any meds, not interested. We have a conversation, I sort of give them education. That doesn't change their mind that visit, but then I'll see them again, right? Somehow, right? Like they end up coming back or whatever. I see them again, they're like, yeah, I remember the thing you were telling me about the Suboxone. And, whenever I hear a patient's like, I'm just not going to use. I'm like, you're going to treatment? Oh no, I'm not going to go to treatment. I'm just not going to use anymore. And I think that that almost never works. That just not use without any kind of skills, counseling, or support almost never works. And so, so the education for patients around, doing this without medications or counseling or support usually doesn't work. And the medications are pretty feasible. They're easily available. You're talking to me, I prescribe them. Patients will sometimes remember that.
Right. It's just like your little seed planting a few times.
Exactly.
Opportunity.
Yeah.
Okay. I was thinking, because the places where you trained have had state level healthcare for so long.
Yep.
Much longer, so that they've had access to these medications for like cheap or free or just much more available. It's a lot of extra work, I guess, being here, having to destigmatize for patients.
Well, that's why I moved back to LA, is to work on this stuff. So yeah, so it's a lot of work, but that's what I'm here for.
One of the things I wanted to ask about, and certainly I know we've got people who are, most everyone is already a nurse and they're completing their nurse practitioner training.
Yep.
that are on, but so please feel free to drop any questions you have right into the chat. So Dr. Hurley can answer any of the questions that you put in the chat. I kind of wanted to go over, you've talked a little bit about educating the patients, but it's like, what kind of happens during these first, like an initiation visit? Mm-hmm. And one of the questions I also have is, I think COVID right now, which is there's been changes in regulations. We can't do as much collecting of labs or seeing patients in person. And, here's a new medication for some of these folks that would be, it's not a new medication, but it's new to those of us who are going to be prescribing. And so it's like, what are some of the changes that you've seen during COVID as well? And then also pre-COVID, what does that first visit look like? And what does it feel like from a patient perspective?
Yeah, totally. Well, I'll say before COVID, a typical visit, you would bring the patient to the office. If it's a patient that, you need to do screening and diagnosis on, you do that. I liked to get UTOXs. Now, I didn't get it every time, but I would sort of explain to patients like, look, I'm not trying to catch you. I'm just trying to let's see what's in your body today, and we'll have a conversation about it, right? And the use of toxicology in clinical medicine, we probably have spent a whole sort of talk on that around how it's not meant to catch people. It's meant to support people. It's sort of like monitoring potassium when you diurese somebody, right? Like, it's just, you want to sort of see how somebody's responding to treatment. So you get a urine toxicology, and in my case, usually to verify that they're using opiates, right? Somebody comes in, they say use opiates. Okay, let's get a UTOX. Let's see what opiates you're using. Is oxycodone? Is it heroin? Because there's different strips for a couple different opiates. And then I, walk somebody through the process. And there's actually, you can get handouts that go through how and when to take buprenorphine. Handouts on, this is where the methadone clinic is, you want to go, or handouts on, what naltrexone is and how it works. But with buprenorphine in particular, you'd start it, you write a prescription, with some instructions, you would send the patient to the pharmacy, the patient would go pick up the medication at the pharmacy, and then once they were in a little bit of withdrawal, and the usual rule of thumb is, you go through the clinical features of withdrawal, which are things like, your pupils, the piloerection, upset stomach, tremor, tachycardia. Any 3 of those is enough, right? You don't have to do what's called a COWS scale. You don't have to do like some structured assessment. If you're getting like at least 3 features of opiate withdrawal, you're sick enough to take your first dose of buprenorphine. So the patient doesn't have to be like overtly vomiting or in like terrible, extreme pain. 3 is enough. Three, clinical withdrawal features is enough. They put buprenorphine in the tongue, and then usually we have them start with a lower dose, like 4, sometimes 8. And for a lot of people, that's enough. They feel better with 4, they feel better with 8. Some people need more, and so they titrate every hour or 2 until they're not feeling any withdrawal. And then the next day, they take whatever the total amount they took the first day, they take that the second day. And sometimes you would do a telephone check-in at specialty clinics. Sometimes the patient would actually physically come back the second day, right? And you sort of talk to them about what they took. But usually you're following up with patients the first week, right? Like let's say you start on a Monday, you follow up with a call Thursday or Friday. A phone call is sufficient. And then you'd have the patient come back probably the next week, pee in a cup, in this case, to see, are they still using opiates or not? And it's not a problem if they are, but you would want to see, because for some patients with buprenorphine, they stop taking their opiates. And they feel much better, right? Like they feel great. I've had patients like cry. I show them their urine cup and they're crying. It's the first time I've been off of oxycodone in like 5 years. It's a very meaningful thing for patients to sort of be able to demonstrate that they were able to come off opiates. And also to see, did they take the buprenorphine, right? Did their urine show that it had buprenorphine in it, which was another thing that I tested for. And that was the typical process of starting. And then once they found their dose, they were on the dose, and that was it. And there really wasn't much to it. Like I said, insulin's much more complicated to use. Titrating things like beta blockers, where you have to sort of titrate to heart rate and blood pressure, is much more complicated. With buprenorphine, you just give patients buprenorphine. They sort of titrate the dose. And then Kathy asked, how long do patients need to be on these opiate withdrawal meds once they started it? So the answer is not a day longer than necessary. For some patients, that may be their entire lives, right? I sort of think of buprenorphine the way that I think about insulin in a type 2 diabetic, right? There's people with type 2 diabetes that's driven by obesity and inactivity. If somebody was to exercise and was to lose weight, you can actually convert somebody from insulin meds back onto oral meds. It's possible. And there are patients that, have dramatic weight loss and dramatic, exercise, and they get themselves off insulin, and it's great. For a lot of patients, they need that insulin, right? Like they don't diet, they don't exercise, and they need to stay on it. So your question is, how long do they need to be on it? Not a day longer than necessary. But the key is individualizing when you take patients off. There's a bunch of clinical trials that are done on this. They keep patients on it for like a week, a month, a year, and then and they'll have a group of like patients that are on it for a month, and then taper it off, versus people that are on it for a month and they get to stay on it. And every one of those studies that compares tapers to maintenance finds that the people that are tapered off do worse. And my critique of that literature isn't that nobody can get tapered off. I taper people off buprenorphine all the time, right? You totally can, but it's individualized to when the patient is ready. And how do you know somebody's ready? Well, what is their life like, right? Are they still hanging out with the people that they were using with? Are they still living in the same place where, have they gone from unemployed to employed? Like, there's other sort of features of like, how well is somebody doing in their recovery that indicates whether or not they're ready to come off. And there's no reason to get patients off if they are okay with being on it. Yes, patients are on buprenorphine lifelong, and that's okay. But neither do I think it makes sense to force anybody off either. It's not like, oh, it's been 6 months, time to come off. Like every study of forced tapers shows the same thing, that patients relapse once they're forced off. But patients that are ready, I taper people off buprenorphine all the time. And for some, it's 2 months, for some, it's 6, for some, it's 12. And I think if you look at national averages, most patients stay on buprenorphine for roughly 6 months. And most patients that come off buprenorphine come off before they're ready. So I do tend, when I'm treating patients with buprenorphine, I tend to do a lot of reassurance. And I tend to do a lot of like, are you really sure it's time to come off? I tend to probably encourage patients to stay on it for slightly longer than they might otherwise want, to really sure that they've gotten the counseling, the support, that they've organized their lives in such a way where they're not going to go relapse. So that's how you start buprenorphine. It sounds like it's a lot of words. The truth is there's a lot of patients that get it very quickly, and it can be a very fast visit.
Let me see. One question I have, so how and where is it initiated? So it sounds like it's done at home on their own time.
Yep.
Maybe in specialty care, it's dispensed or given that first visit is like observed, but most of the time it's not observed.
Most of the time it's not observed.
And then in COVID world, have we seen changes because there is a loosening of these regulations?
Yeah. So we used to not be able to start buprenorphine unless you had a an in-person visit, or you were allowed to do a telehealth visit if the patient was with another DEA registered provider. So hypothetically, if let's say Sherry's a nurse practitioner at the clinic and I'm an X-waiver doctor, the patient's with Sherry, but Sherry's not going to prescribe it for whatever reason, right? Like Sherry,
but I'm there with the
you're
patient.
there, but you're not X-waivered, right? You're there, but you're not. But you have your DEA certification. I'm allowed to telehealth in, see the patient as long as they're in the room with you, right? As long as they're in the facility. So it was weird, right?
Yeah, a lot of barriers to
all these barriers.
Yeah.
All of that's been suspended. You are now allowed to start buprenorphine with a phone call. And so actually that's one of the programs I've started in LA County is we now have a phone number that providers can call to link us directly to patients. It's not a phone number for patients, but it's a phone number that like a patient could call, and you don't even have to do a telehealth visit. You can do a telephone, right? Like on the phone, talk to patients. And so we don't have urine toxicology data, but we do have the patient's history. We have cures. We have whatever collateral we're able to get out of the medical record. Like, so in the county, we have like a consolidated medical record. So I could see any hospital visit that they went to. I can see if they've been in the mental health system or the emergency room or, you know, in a clinic. And so you sort of look at what can you get in the record? What's in cures? What are they reporting? And if they're reporting a history, if these things match, right, there seems to be some reliability to the information you're getting, you're allowed to prescribe buprenorphine, and legally allowed to prescribe buprenorphine. And now we're doing it with really limited toxicology, right? Like if you can get a patient in for toxicology, and sometimes you can, that can be helpful. But at this point, usually we're prescribing even without getting regular urine toxicology information.
Now, do you think this has been like successful enough or demonstrated enough that it's been life-saving or working so that post-COVID these regulations won't be sort of re-regulated or redone?
I do. I mean, what the legal framework under which the regulations were loosened was because the Secretary of Health and Human Services declared a public health emergency, and that freed up the DEA, the National Health Coordinator for IT, freed up SAMHSA to be able to issue kind of emergency regulations. For those to continue, they would need to put those into law. But I think that, you know, one of the things we haven't seen is a lot of buprenorphine related mortality, right? Like we haven't seen any problems with sort of buprenorphine with patients.
And actually, and to the contrary, we've seen rates of substance use disorders and mental health issues get worse.
Get worse.
With COVID.
That's right. And so there's more of a need for access. And so I'd like to see some of these changes be made permanent, and I hope they will be. One of the questions that came through on the chat is, do I use contracts? So I actually don't use contracts. There's actually no evidence that contracts change behavior, right? I think there's a fantasy of, oh, I have this patient on an opioid contract, so now they're on contract. There's no evidence that the contracts help or hurt, in fact. So what I do with my mobile patients is the patients that I'm sort of not seeing directly is we do telephone check-ins. I will ask patients around, you know, are they participants participating in Zoom counseling, right? Or, you know, most care now is being delivered virtually. If there's ever a serious question, if I really doubt the person's taking buprenorphine, I probably will then insist on, hey, like, here's another week, but if you need anything after that, make sure you show up at the clinic this week to drop off a urine, right? But they don't have to coordinate that with my availability, right? They can go, like, I just order urine from a lab, whether it's my clinic's lab or, you know, in my private practice, I send people like Quest or LabCorp or, like, you know, a local community lab to go give urine. And but most of the time, you know, when patients, you can sort of see it in telehealth or hear it in their voice when they're clear. And there are people that you can tell when they relapse, right? They're slurring, and it's like, you're like, okay, like, this is clearly not going well. But yeah, the actual process of engaging patients around buprenorphine is not, in my mind, any more challenging than around the treatment of other chronic conditions. You know, if patients aren't doing well, then we sort of consider, oh, Tina says, you work as in an ER as a nurse practitioner. They love contracts. I've never seen the value. I would, your intuition, I think, is correct. I'm concerned on follow-up to me from primary care. So a couple things about that. One of the things that we've launched, or that we're in the process of launching, is a website called losangelesmat.org, where you can actually find public sector community health centers that offer buprenorphine. We have a soft launch right now, but that we haven't, like, publicized it more widely because we want to actually build a registry that's searchable and functional. But we have, like, a PDF up there right now where you can sort of download it and sort of look at what community health centers offer MAT. There's also a website called choosemat.org, so CHOOSEMAT.org, which just lists, you know, a bunch of waiver providers that are on the SAMHSA registry for buprenorphine. But the thing to buprenorphine out of the ED is a couple things. The first thing is, when patients are in the ED in opioid withdrawal, if you send them out with a supply of buprenorphine, at the very least, they're not going to go, usually, they're not going to go use right after they leave, which is what usually happens with opiate use disorders. You get sick, you know, you want to go use heroin, so you leave AMA and you go shoot up, right? And, you know, God forbid you go shoot up and there's fentanyl and you overdose. So that's what usually happens. So if you give somebody buprenorphine, you're at the very least breaking that cycle for at least the however long they get the prescription, 5-day prescription, 7-day prescription. You know, at the very least, they now have enough to, like, break the cycle of use and withdrawal and use and withdrawal. So even if the patient never follows up with primary care, even if there's absolutely no continuity, at the very least, there's some mortality benefit. And it's a non-trivial mortality benefit to even, like, one dose of buprenorphine, right? So even if we haven't sorted out exactly where the patients would follow up, there's still benefit to starting it in ED. And the second thing is, you know, patients may remember that and actually seek out a buprenorphine provider. They may not be ready to do it, like, right then, that week, but exposing patients to buprenorphine actually increases their readiness to get buprenorphine at some point in the future. So I wouldn't let the concern around, we haven't perfectly mapped out a continuity plan. I mean, if you're able to, like, get a bridge clinic out of your hospital and get patients linked and do care coordination, that's all wonderful. In fact, you know, that's the Yale model that was published. They do a lot of care coordination, but Yale's also in New Haven. It's a small community, right? Like, it's not hard to track people because there's just a relatively finite number of people and places. In a place like LA County, it's, you know, 1,000 points of light. It's this gargantuan universe that's bigger than Connecticut, right? It becomes harder to do that kind of care coordination. And care coordination is important, but I wouldn't use the patients don't have perfect follow-up, so therefore I can't treat. I would say actually the reverse, treat, and then, you know, use the patient response to buprenorphine to help build capacity for that kind of follow-up. But I wouldn't let lack of easy access to follow-up stop me from starting a patient on an effective treatment.
Brian, I know there might be other questions in the chat because I can't, in my view, I can't see the chat, but one question I have for you, and please ask questions because we only have about 5 minutes left. And one of our goals is to kind of do what my last question is to you about, which is, you know, not everybody in the medical field is cut out to address substance use disorders for a variety of reasons. Some people, they just aren't comfortable with this population. They're probably treating this population anyway because we're seeing them in all sorts of sectors. But there are some people who come to this and and have an interest in it. And, you know, who is it that, you know, how do we get more people to do this? We have a need for nurse practitioners to be interested in doing this, to want to do it well. And in the work that I'm doing, the nurse practitioners with PCSS and AAAP that do this work are amazing. Like they are working at the top of their license. They are doing so much incredible work. How do we get people like the folks that are here to, you know, make this their mission or champion this effort? And what does it take? You know, from your perspective, you've been doing this a long time. How do we get people engaged in this?
Well, we get people engaged when there's a system, right? So one of the things that's been really helpful for me is that I have professional homes at ASAM, which is the American Society of Addiction Medicine, CSAM, the California Society of Addiction Medicine, both of which are fully open to nurse practitioners. I'm also a member of the American Academy of Addiction Psychiatry. It's the organization that like sponsors PCSS, that, you know, is a big proponent of support. So being connected to a network of people that does this is really important, because I work in a health system that doesn't have strong protocols. Now I'm lucky that I have a position in a health system where I got to develop them, right? Like I was charged by the leadership of the Department of Health Services to, you know, develop things like protocols and practices. But one of my challenges is in my role, like I only work in a couple different places. And so there's a lot of places I don't work where like the leadership are not excited. And so if I'm a nurse practitioner coming out of nurse practitioner school and I'm really interested in this, it's either finding a place that already does it, right? So I'd be part of a team where I'm supported in offering medications for addiction treatment, or be prepared to be a champion in a place that's not. And most places that don't take on prescribing substance use disorders, it's like anything. It's like quitting smoking. It's tenacity. It's sort of like you stick with it and you keep the message going of like, we can do this. Like this is feasible. Like this is not a very like we're already seeing these patients, right? Like you know, this is idea we don't see.
They're coming to our ER. They're coming to our doctor's office. They're coming to our mental health clinics, right?
But you know, if you're not looking for it, it's easy for to have this impression. We just don't see those patients because you have some idea around what those patients are. But when you start asking people, and I actually think like Suboxone is available here is a great screening question, right? Because you know, a lot of people, not everybody in the community, but there's now more awareness of what this medication is and how it works. And so, you know, letting people know around this treatment's available can be very helpful at galvanizing interest. And then, you know, being a presence to do the organizational readiness steps is oftentimes the overlooked piece. We sort of think, oh, you have a waiver, you can go prescribe. And yes, you have a waiver, you can go prescribe, but there's really organizational readiness steps to operationalizing this treatment in a health system.
One of those things, as you're saying this, reminds me, our initial hook here is that Dr. Hurley and Dr. Matt Torrington, who will be on next week, are both people who are super expert in this. And they're also good people to reach out to. So like if you have questions or interest at all, this is how we can filter for you. You can email us and we can sort of link you, because I always find that the people who treat addictive disorders are very passionate about it, and they're willing to, and they're really giving compared to other areas of medicine. Like we want more people to sort of be good and be interested in this work. The other thing is, I think sort of moving forward, there are, Brian mentioned PCSS, there are mentorship programs, there are so many resources that we can hook you up with in terms of network. So there are SAMHSA and has funded so many efforts to ensure that you don't feel alone in this process of starting to prescribe, and that you feel like you have a professional and a network that can support you, and a phone call to pick up and reach someone who knows exactly what they're doing. So I would encourage you to continue to keep in touch with us through Azusa Pacific, because we are going to be your link to be able to find these other resources for you. Brian, it's now 5 o'clock exactly, so I won't keep you longer, but any parting thoughts? Those of you in the chat, I think there's going to be a link, if there isn't one already, for you to be able to complete your
There is. Yeah.
But any parting thoughts for these folks, or any final questions for Dr. Hurley?
If anyone has any questions, I was going to say, you know, this is you know, buprenorphine is a super high impact medication that can, you know, saves a lot of lives. that sometimes, depending on the health system you join, you might need to amend the collaborative practice agreement you would have with any physicians at the clinic in order to include buprenorphine. Happy to be a resource if anyone has any sort of language. And then the last thing that common questions I get is, if I have a collaborative practice agreement, does the physician that I work with have to be waivered? And actually, the answer is probably not. When I say probably not, there is no like clear statutory language in the California nursing code. But the legal analysis from the California Primary Care Association has said, you know, we actually don't think that you have to have a CPA with a waiver doc in order for you to be able to prescribe buprenorphine. So, so in other words, if and when you encounter barriers in your systems of care, there's a lot of us that try to work on addressing those barriers. Like, let us be a resource to you.
Great, great. We totally appreciate it. Brian, I want to thank you again. You always are a wizened resource for those of us in this field with a lot of good connections across the county. I want to thank you guys all for joining us, and I hope you come next week. Next week, we're going to move just into a little bit more of like complicated cases. Again, what happens when your patient is pregnant? What do you do? What happens if your patient has pain issues or is going to go in for surgery or things like that? What are some of clinically, how do we treat some of those cases that seem a little bit more complex? And again, we want to thank you, Brian. We appreciate it. And thank you to all of you who joined today, and have a good night. Thank you.
Thanks, everybody.